everyone. Thank you for joining us in Hall F for the first session of the day. And what we are going to be talking about today is my first in cataract surgery. This is a unique session in the sense that the intention of this entire course is to make youngsters, people who are general ophthalmologists who have probably done a short-term fellowship or a long-term fellowship in cataract surgery, who have been doing routine cataracts and have not had a chance to first-hand do a premium lens like a multifocal toric or a complicated case or something like a phakic lens. So we will cover all these aspects in how one can go about planning and executing their first of such cases. And without wasting much time, I'll start off with my topic for today. And I'll be sharing my experience on how we can plan our first toric lens case. So can I have my slides, please? Right. So planning my first toric IOL case. Uh, so toric IOLs basically, if you go to say, are not very difficult to do once you do a good phaco surgery or even probably an SICS surgery. It just needs understanding of few things, and that is what I'm going to be discussing here. So there are two sets of things which need to be understood for toric lenses: the theoretical concepts and some practical aspects. So when we talk about what theoretical aspects you need to know, there are few of them, four to be precise. Understanding of PCA, which is posterior corneal astigmatism, that is something that needs to be understood before you venture into toric lenses. The second is SIA, that is surgically induced astigmatism. Again, something which is less understood and needs to be understood better. Then the biometry part of toric lenses and certain nomenclatures with respect to toric lenses. And the practical aspects of toric lens planning are, the pre-operative marking, which is an integral part of the surgery itself, as I'm sure most people would be knowing. And then the intraoperative, guidance, the things that you do differently for a toric lens. So I'll try to cover all these, quickly today. Okay, coming to, according to me, the two most important and misunderstood things when it comes to toric lenses for beginners are posterior corneal astigmatism and surgically induced astigmatism. Now, both of these are things which have been evolving over the last few years. These concepts on these were not understood before, and now they have been understood much better, and as a result, toric lens planning and the results with toric lenses have become much better. So I won't go into detail about posterior corneal astigmatism, but I'll just share an example with you. These are two photographs taken from the Lenstar readings. The one on the left you can see shows the astigmatism of 0.9 at 97, and the one on the right shows again a Lenstar reading showing 0.79 at 24. Now when you say the astigmatism reading, when there's no minus sign, you're talking about the steep meridian. So it's telling you that in the first photo that it's 0.9 at 97, that is the steep meridian. And so this is a with the rule astigmatism because it is steeper vertically, and the second one is 0.79 at 24, which is steep horizontally. So it's a against the rule astigmatism. Now this only is from the anterior cornea, and this is what our traditional keratometers and even the early biometers used to give us. But for toric lenses, considering the posterior cornea also is very important. Now posterior cornea does play an important role, maybe not in all cases, but definitely in few cases. And below, if you see the net astigmatism which has been got by calculating the posterior corneal astigmatism, in the first case 0.9 at 97, the net astigmatism considering both anterior and posterior became 0.44 at 103. So it came down significantly, whereas the net astigmatism for the against the rule case from 0.79 has become 1.07 at 15 degrees. So what has happened is when you consider the posterior cornea, the astigmatism for with the rule has reduced and for against the rule has increased. Now this is what the effect of posterior cornea is. fortunately for us, most of the modern day calculators, even if you can't measure, have very good nomograms, and this is taken from a nomogram. So nothing much that you have to do yourself. You can easily just feed in that the posterior corneal nomogram and this will be taken care of. But understanding it is important. The second concept is surgically induced astigmatism, or SIA. Again, this is not something that I'll go in detail, because recent studies from Warren Hill and all have shown that your SIA has to be closer to 0 than to take it 0.3, 0.5. And I would say only one thing: if you're starting off toric lens practice, for your first few cases, just keep your SIA 0, and that is proven statistically, and literature has shown that keeping it 0 or close to 0 is beneficial. So I would say starting cases, just keep it 0 and you'll be safe. Coming to your other two theoretical parts, that is your biometry and nomenclature. Now when you say toric IOL biometry, I would say you have individual IOL company IOL calculators which have their own, but the safest and the best calculator which you can use is the Barrett calculator, which is freely available online. And for the latest version, you should go to apacrs.org and go to the Barrett toric calculator and just feed in the details there. That will give you the best results. So you feed in all whatever you get from your keratometry, axial lengths. Ideally, for starting your toric case, again, if you want to be safe, an optical biometer would, according to me, be a better option than going for keratometry from an auto-ref and ultrasound, because the optical biometer gives you all the parameters that you can feed in. And you feed in all this and you get your toric lens. It will tell you what is the power of the lens, toric lens, the spherical lens, and also what axis you should implant it. So this is with respect to biometry. Now understanding the nomenclature is important. So most of your toric lenses come in T2, T3, T4, T5, and all these basically are nothing but your cylindrical powers in different at the IOL plane. So these are some of the common companies which have toric lenses and what is their nomenclature. Again, this is a chart which I prepared for myself. So if I have to implant a biotech, I know HFY 40 means 4.5 diopter, or ZCT 225 is 2.25, which is equivalent to T4. So understanding this nomenclature is important, so you know what IOL power you are putting. So that was with respect to the theoretical part. With respect to the surgical part, the pre-op markings and the surgical part itself. Now pre-op markings, we all know that you have to do the pre-op markings in the sitting position before surgery. And the reason for sitting position is so that there's no cyclotorsion effect. And you have various markers which help you to get 0, 180 degree marks. You have the bubble marker, the gravity pendulum marker. You have, you can do a freehand mark. There are many different methods. I would say for a beginner, you should use a freehand mark, because to start off with, it is best, and then probably if you're not comfortable with that, you can go on to doing the, one of these markers. So I'll just show a small video to conclude. Okay, this is just a video to show you how you should go about doing a marking. You should dry the area well after you've put your Paracane eye drops, and putting a speculum at least in the beginning is really important. You put the speculum, you make the patient sit on the slit lamp so the chin is stable, and this is just showing you how you can use a simple one of the gravity markers. And the inks are there. This is for 0, 180 degrees. Ask the patient to look straight. Probably you can put in a torch light and just mark it at 0, 180. The only issue I feel with 0, 180 is that you sometimes end up with parallax errors, because of this. Sometimes when the patient is looking up, your marks go slightly lower. So for me, at least for beginners, I would say like this: a freehand mark at 6 o'clock position, which will give you your 90 degrees, is very safe, and you can just do it very easily as well. And it gives you good results if you do it correctly. Now you should try to do it as close to the center as possible, so it will be 90 degrees, but you have smartphone apps which can help you to get better results with accuracy. Okay, coming to surgical part. So after you dry the area well, now I've got a single freehand mark which is at 100 degrees, which I've confirmed with my smartphone. So I'll keep my Mendes ring. So it's important to dry the cornea well before you put the Mendes ring. I keep the Mendes ring at 100 degrees, and now my IOL has to be at 20 degrees. So I don't use the fancy equipment, I just use a Sinsky which has a mark, because I want, point marks. I don't want the line marks because they can also lead to parallax errors. So I mark it at 20 degrees. This is pretty straightforward. Once you do this well, I've got my 20-degree marks, and you can just continue your phaco routinely. Once you've implanted your lens inside, one of the most critical steps is to remove Visco very thoroughly from behind the lens, so that you get good rotational stability immediately post-op, and the Visco doesn't make the lens rotate. And then you just have to, I use a dialer after removing the Visco to nudge the lens into position. And my final nudge comes from the irrigation itself, just gently nudging it into position until I feel that they are aligned with the marks. And you can see that how well the lens gets aligned with the marks when you use simple point marks. So these are just some of the tips and tricks which you need to understand while planning toric lenses, and that's about it. So thank you. Yeah, Ronak. Yeah. 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 Yeah, because I use an app, but before using the app as well, I used to use freehand mark. I mean, yes, if you are not, yeah, it could shift. It could shift. It could shift, right? It could shift. Yeah, yeah. So, right, right, right. Very true. Uh, True, that is also a good way of doing it, so that you hydrate the incisions and do. I mean, there are so many different ways. It's just that the basic things of doing it remain pretty much the same. The basic principles. Okay, I invite Dr. Ravish, who is our next speaker, who will be talking on planning my first multifocal lens.
Okay, good morning one and all. Thank you Zain for such an elaborate session on toric IOL. I'm Dr. Ravish Vaishnav. I'll be talking on planning my first multifocal IOL. As we know, routine phaco with monofocal IOL forms the bulk volume of our practice, but we need to shift gears and we need to move on to doing premium cases, provided we are prepared with the right technical skills, the right amount of knowledge, the correct instrumentation, and a proper planning for each and every case. Initially, I was not very sure as to how and when to start with the premium cases, as I didn't have the resources with me. I was new into private practice, and also I was not very confident as to how to go about with it. During my private, I had been visiting around at few of the places, so that helped me a lot. The idea was to learn from the senior doctors, to see how they plan the surgeries, how they go about with the premium cases. Also, I would be able to cater to more patients, so I could get the premium clientele to my resources, and I could also make a name for myself. It's important to be in touch with the public, so I had some workshops and webinars where I could educate them about the options for cataract surgery and spectacle independence. I spoke about the different myths what they had. This goes without saying, you need to be seen on Facebook and Instagram these days. People do follow you, and then they can follow up in your OPDs also. I worked on my cataract surgical results. Right from the lower budget patients, I tried to aim for 6/6. Eventually, for hopefully, hoping that toric and multifocal would follow. I did OCCIs, LRIs, and obviously a good happy cataract patient would refer to you few or more cataract patients. So eventually many firsts did happen for me. A first topical case I did in my private practice, followed by a first toric case, which went off pretty well. Patient was happy. And recently, very recently, almost 2 weeks back, I had my first phakic IOL case. But the case which did make me think a lot, plan a lot, was my first multifocal case. I would divide my case into 3 segments. The pre-operative one, which is the most important one, followed by the intraoperative, where you need to deliver the results, and the post-operative, where you have done your part, you could just pray for the best to happen. The pre-operative workup, it's very important to choose the right patient, and after you have chosen the right patient, the thorough counseling which has to be done following it. The pre-op examination, which has to be done just to rule out the contraindications, followed by the pre-operative scans to look at the eligibility for the multifocal lens. So the right patient depends on the following criteria. It has to, age of the patient. Younger the patient, more the or faster the neuro adaptation, so better the result. Depends on the occupation, the hobbies what the patient has. Requirement of nighttime driving could be a factor which may not go in favor of multifocal, as it might cause glare halos to the patient, which would already happen in a multifocal lens. The psychological profile does matter a lot here. A patient who is overly critical with expectation of perfection usually are the most unsatisfied ones. And multifocal are best suited for patients who are highly motivated for spectacle independence and are ready to accept some amount of dysphotopsia which may follow after the surgery. So my patient did fit the bill perfectly. His age was 55. He was almost into retirement. Occasional desk job he had. He was a happy-go person, was into reading a lot. So I did go ahead with the surgery. Obviously, the counseling took major of my chair time. I spent the maximum time here. I cleared each and every doubt of his. I did explain the procedure thoroughly to him right from start to the end. Also the possibility of glare and halos or dysphotopsia happening post-surgery. I did tell him about the neuroadaptation, which may take from 3 months to 1 year. Then came to the pre-op examination. It was basically to rule out the contraindications. My patients luckily didn't have any of it. But if a patient has dry or MGD or anterior blepharitis, for that purpose, has to be treated well before the surgery. A corneal scar is a big no for multifocal. Pupil has to be looked into. A small myotic pupil would not give him a good near vision post-surgery. A larger pupil would cause glare halos. ZD cases are a total no for a multifocal lens. So likewise, glaucoma and macular disease patients which should not have a good contrast. As always, the contrast already compromised in a multifocal lens, and amblyopia and strabismus patients also may not be the ideal ones. Then came the scans. Lenstar or a biometry, I would say, would be ideal for planning a multifocal lens. One, it helps you to get the right amount of cylinder in the cornea, and also the perfect or the precise accurate IOL power calculation can be done here. The cylinder has to be comparable with a topography. As you see here in my case, patient had a 0.4 cylinder in both topo and Lenstar. Also the ARK cylinder was comparable, it was around 0.25. The topo maps were in normal pattern. Need to screen the retina well. You have to be sure about the macula. Get a macular OCT done. My patient had a pretty decent foveal contour, so I went on to the next step, that is the surgery. It's basically planning the surgery right before actually doing it. So you need to plan the incisions and the rexus and the side ports. So the incision has to be on the axis always. It has to be a good firm incision. That is, it has to be away from the center so that it causes less of astigmatism. Side ports, I believe, have to be of adequate side because a larger side port could cause some astigmatism. And very, very, very important is the rexus. It has to be circular, continuous, and a centered rexus to have a good IOL overlap. Okay, I come to my surgery here. So this was the patient. I start with the incision, which went on pretty fine. Followed by the side ports. It's important to form the AC well before starting the rexus. And the rexus part has to be very gradual. You have to be patient and slow. You can always take the pupillary margin as the guide. Use the microscope lights toward the centration. It has to be a circular, continuous, and a well-centered rexus. My patient had a softer grade of cataract. It was NS1 with a central PSC, gentle hydrodissection. The softer ones can be tricky at times. In this case, I could just get the nucleus emulsified without chopping it. I tried to get it out of the bag as much as possible, and I could eat it up in the AC itself. You need to do a thorough cortical cleanup, with no remnants of cortex. AC polishing would help to delay the capsular fibrosis and help in the better centration of the lens. Comes to the loading of the lens. The loading has to be precise, rightly done, slowly done in the cartridge, followed by a gentle and a gradual implantation into the bag. I'm sorry, I lost the centration of the video here. Now, very important is to remove the visco from the AC and also from behind the lens, because visco left behind the lens could cause decentration of the lens. You can use the microscope lights to center the lens, and once you're sure about the centration, you can hydrate the wounds. Always recheck before closing the patient, closing the eye, or even after removing the speculum, you could just check once again. So post-op day 1, this was the day where I could hardly sleep. The night before, I mean. The patient was happy, so was I. Patient had a decent vision, 6x6 blur with a good near vision. The lens was centered. I did dilate to confirm it. Then, I waited for a week for the eye to settle, for the astigmatism, the refraction to settle down. I planned the second eye surgery, which was pretty much similar in the parameters. And post the second eye surgery, that is 2 weeks later, this is what the patient had. He had a good 6x6 and 6 vision in both the eyes, and he was happy. I did explain him about the possibility of dysphotopsia and glares and halos. He was quite patient to hear about it, and it's been almost like now 6 months post-surgery. He's doing pretty fine. Thank you so much. Yes? So it depends on the rent, sir. A smaller rent, I would still proceed, but if sub-incisional rent, yeah, I won't proceed further, sir. Yes, so true, sir, true, sir. I did keep the IOLs backup ready for my case. This case, I had 3-piece ready. I even had a monofocal lens ready. I did explain to the patient about the chances of complications happening in a routine case also. So it was all explained and. Sir, limit of around 0.7. Around 0.7 is what I take as a cutoff for a non-toric multifocal lens. Beyond 0.7 or 0.8, I usually prefer the toric multifocal, sir. Yes, sir. Yes, sir. Yes, sir.
Select a housewife or somebody who's not that demanding in the beginning, since you're just starting to do multiple?
Sir, yeah, I would say, yeah, that would be right way to go about it. A patient who is not very demanding would be the better choice for as a beginner to. And this patient also wasn't demanding. As I said, he was into a retirement phase and not that much educated. So he was into reading a bit, yes, but not a desk user, not a computer user. So I felt he was the right one, and I mean it eventually happened well. So.
And also as a beginner,
Yes, sir.
would you go in for a trifocal or a bifocal?
Trifocal, obviously, sir, the patients can be very demanding, and so I would prefer going for a bifocal or a multifocal first, followed by trifocal. Once I gain the confidence, once I know about my SI and all, I would eventually I haven't, to be frank, I haven't yet done a trifocal.
Your surgery was very good, everything was okay, but
Yes, sir.
only thing is nowadays the trifocal lenses are supposed to give less glare than bifocal.
True, sir, true, yes, yes. Not available, correct, sir, correct. This was some time back, so I could do it, sir. Short supply, right, sir, right, sir.
Very good surgery.
Yes, thank you, sir, thank you.
I invite Dr. Prajakta for the next talk, which is going to be on my first case in topical phaco.
Good morning all. I am Dr. Prajakta Paritekar, consultant at RJ Shankar Eye Hospital, Panvel. So on no financial interest. So on 24th June 2021, I started my practice as a consultant at Shankar Eye Hospital, Panvel. It was a new place, new environment. So I decided to take it as it comes. So for the first time in my life, I was enjoying the pros of being a consultant. I had my own private patients, own consulting, freedom of decision making. No longer I was answerable to anyone, and I did not have to take any orders. But at the same time, I had to face the cons of being a consultant, that I had to deal with demanding patients. Sometimes the patients have unrealistic demands, like they want injection-less surgery, they want painless surgery. I'm sure all of you also must have faced them. And they want miraculous vision recovery at the post-operative day 1. So, so I had to somehow step out of my comfort zone, and that's where the magic happens. So I gathered guts and I made a decision to do my first topical cataract surgery. But before taking this decision, I first asked myself whether I was comfortable doing a uneventful cataract surgery under local anesthesia. When that answer came as yes, then only I decided to take this leap of faith. So, but how to plan and how to go about it? So I discussed with my colleagues. All of them were doing their topicals. They already had achieved their milestones. So I discussed with them and asked them. They shared their tips and tricks with me. Thanks to internet, we have a lot of YouTube videos. We have a lot of learning stuff. So I went through the videos, and there was a lot of tips through the videos also. Then I did some literature search to know which topical anesthesia which is suitable. And of course, this was a time where I had to put all the teachings that I had gathered during my training period into my practice. So I designed a stepwise approach: selection of correct the patient, counseling, pre-operative preparation, intraoperative modifications, and post-operative modifications. So in selection of patient, this is a very important criteria. So during the OPD, while examining the fundus itself, you get a fair idea whether the patient will be cooperative for topical or no. Many times patient doesn't even open the eyes for a normal fundus examination on a 90D or a 20D. So that patient might not cooperate for a topical surgery. You can further confirm it by putting a torchlight and checking the fixation. While giving chair time, you get a fair idea about the patient's personality, how demanding he is, how calm he is, whether he'll be able to follow your commands. Again, it's better avoided for patients who are hard of hearing, very old, mentally retarded, or dementing, because during topical surgery, we should have a conversation with the patient, and if the patient is not able to comprehend with your instructions, then this may not work. Of course, we are dealing with geriatric age patients who have a neck and spine deformity. So for many of them, it's difficult for them to lie down straight for a span of 30 minutes or so. So those cases also may be rejected for topical. Again, counseling is very most important step. Patient should be made aware of the full procedure, because we tell them there is no injection, so patient feels that it's going to be a painless surgery. Of course, it's going to be a painless surgery, but patient will keep on having some mild pressure sensations, so that has to be made aware to the patient. Maybe we can demonstrate it with a pinch on the hand. Many people have a doubt that will my eyes be, how will my eyelids be open? Movements I'll control, but what about the eyelids? So we have to tell them the role of speculum there. Also, the visual sensations is not lost during topical surgery, so we have to tell that also to the patient. Then most important thing, which drug to be used. So I am in an institute, so we have a set protocol, and which is put in place by many of the seniors over the years. So my protocol in my institute is to use a 2% lignocaine jelly. So, but I just thought, let me see what is the new things available and how this this protocol foolproof. So I did a literature search, and I found in the studies that lignocaine jelly is quite effective and good option for a topical anesthesia. My one doubt was whether it will affect the corneal clarity because of it's a gel preparation, but even the study showed that the corneal clarity is not affected. Also, in addition, we can give a 0.25 milligram anti-anxiety medicine night before the surgery. Then intraop modifications is one that we can use less amount of illumination if it is irritating to the patient. Conversing with the patient is important, like we jokingly say it's verbal anesthesia. So we have to keep on telling the patient and to follow our instructions. Screw speculum will be of help because it helps to retract the eyelids. The most important is while doing a rhexis or maybe while doing an incision, we hold the conjunctiva. So that can be done gently because that is the point where the patient feels the pain. Stabilizing the eye with the second instrument. We have to ensure sealed incisions because now there's no patch on the eye which aids in sealing the incisions. And our assistant is used to irrigating the cornea intraop. So that also sometimes can cause irritation to the patient. So that maybe can be minimized and we can put a viscoelastic on the cornea. And post-operatively, again, no patch. The patient will keep on feeling the irritation and watering, so he might go and rub the eyes. So strict instruction has to be given. As far as possible, avoid straining, coughing and sneezing. If there's a pain, we can give some amount of painkillers. So the hero of my first topical surgery was a 2% lignocaine jelly. It was a single application in the block room 10 minutes before the surgery. So this is how we can check the cooperation with the torchlight. Here the patient is little sensitive to the light, so probably in such a case we can use a low illumination. And this is a block room ritual. We put the paracaine drops, followed by apidine drops, followed by painting the surgical area. And then there comes the 2% lignocaine jelly, which is put in the fornices. This is a single application, and then the patient is shifted to the OT. So this was my case, 58-year-old male. He had just a NS1 PSC cataract. He was quite cooperative, so I went ahead and planned the surgery. Somehow, whatever till now I have felt is like males are a little bit more cooperative compared to females, for reasons unknown. Reasons unknown, I said. So then rhexis can sometimes be tricky while doing a topical surgery because if the patient is not cooperative, there is a chance that the rhexis might run out. So followed by hydrodissection, hydrodelineation, the golden ring. It was a soft cataract, so I did a stop and chop. So by this time, I was quite comfortable with my machine parameters, so I could confidently do the surgery. Followed by a biomanual is a very safer step in this because since we are holding the eye and stabilizing the eye with both the instruments. Followed by single piece monofocal hydrophobic IOL injection. At this step also the patient can feel some pain and some pressure, so we have to counsel the patient beforehand. Followed by Visco wash, intracameral moxifloxacin and sealing of the incisions. So next day the patient was happy, so was I because he had unaided 6 parts and 18 vision, good IOP, a clear cornea. So I had achieved my milestone of doing my first topical cataract surgery. So I would just like to say that sometimes all you need is a leap of faith, so just go for it. Thank you.
Due to paucity of time, we'll take questions at the end of the session. That was a very good and elaborate presentation, Dr. Prajakta. Okay, please go ahead. By then, Ronak, you can load your presentation.
It's a single use, disposable. Like we use it one time and we just throw it.
Mike.
But how do you ensure that the first part is also sterile? The gel tube
Yeah.
will have a small opening above it. So that has to be opened by the surgeon.
Okay.
These are the small points where you can get infection and can ruin your things.
Okay.
Or you go in for a simple parakin drop.
Yeah.
You can use it for 4 or 5 patients and then throw it off.
Yeah.
Wonderful surgery.
Thank you.
Thank you, Prajakta.
Thank
Our next speaker is going to be Dr. Ronak Solanki, who will be speaking on my first subluxated case.
Hi, good morning everyone. So I'll be presenting how would you go about doing your first subluxated cataract. So we'll start off with, I won't bore you with the anatomy, physiology and definitions and the devices which are used, because by the time you're planning this, you must be quite familiar with it. Anatomy, as I said, you need to know it because the planning of the surgery and the small steps which may be helpful over there. We'll come to the clinical evaluation. So right before the surgery, you have to plan it well, because this is the first case, so you don't want to take a too complicated case. Especially you don't take the cases which are hereditary, like the Marfan syndromes, where there is a subluxation is grossly decentered. Evaluate the lens position, the visualization of the extent of the zonular defects in terms of clock hours, the AC depth irregularities, the iridophecodonensis, the vitreous present in the AC or no, because that is a very important factor. Pupil changes and the grade of cataract, but the grade of cataract is going to give you the confidence of going ahead with the surgery or no. And a proper evaluation of the posterior segment, because in traumatic cases, you may do one part and you may miss out on something else. So these are just practical steps where the approach to your first case is identify the amount, the amount of subluxation is important. The goal is to save the bag and fix it. Bag removal, if it's to be done, and then you have to plan a secondary IOL. There are various types of IOLs and devices which have their own indications. The grade of cataract, as I said, is important because you don't want to have more complications in terms of zonular dialysis, extending the posterior capsular rents, nucleus drops, and various other things. Vitrectomy also is needed. So the surgical goals are two. There are short-term during the surgery where you have to do a capsular stabilization, and a long-term where the IOL and bag complex has to be fixed. So since it's the first surgery, we'll do a very practical approach where these are the things which I wanted to take care of during the surgery, because every step is very important, right from planning the incision site, the type of incision, because if you suppose you're used to doing a temporal phaco and you always do a temporal, but if intraoperatively or you want to plan a secondary IOL or a CTS fixation, it may just hinder your wound area. The site of the wound is very important. In case you need to convert it, a vitrectomy is done, SFIL or claw fixation. Plugging the area of zonular dialysis, it helps to tamponade and push back the vitreous and prevents the trypan blue from going down. It seems a very silly small step, but it's very important in such cases. A continuous curvilinear capsular X is important. You have to start in the opposite site of the zonular dialysis. Sizing is adequately required. Support with hooks if needed. Use forceps and center on the IOL and not on the Purkinje image, because in gross decentration, you may just falsely, whatever is seen, you may do it and then it becomes an eccentric capsular axis. Hydro procedures, you just need to be very gentle about it. Nucleus rotation, there has to be minimal nucleus rotation. I use a technique where I use capsular hooks to distribute the forces and then rotate the nucleus after doing hydro. Coming to the phaco, there are lower parameters to be used. Use direct chop techniques. Always be liberal in your use of viscoelastics, especially cohesive viscoelastics. Lift up the fragments to prevent stress on the zonules. And keep observing the PC, because your heart is going to beat faster the moment you see your PC fluttering over there. Last piece is very important, because you always have to anticipate that something can go wrong, because just because you can't be relaxed at the last piece. A cortical cleanup is very important, where tangential peeling and peripheral to central pulling is required. Timing of the CTR is a debatable thing. It depends on your surgeon preference and also how well the cortex has been released with your hydro procedures and maneuvering in the bag. Later then, capsular fixation will be required. The lens can be a single piece lens also you can put if you stabilize the bag well. And a 3-piece sulcus fixation and an optic capture can be done. And the worst is you have to plan for the worst that could happen. Keep a standby VR surgery ready. A nucleus dislocation can happen, vitrectomy or via the pars plana approach, and secondary IOLs. So keeping all these points in mind, we went ahead with the first surgery. This was my first surgery a few years back. So I'll just play the video. Okay. It's not playing. Okay. So if you can see that subtly there is a zonular dialysis of around 3 clock hours. I put intracameral adrenaline, which reveals a little more than what I had expected, because on slit lamp it wasn't dilating. Tryphan blue is an important step, as I said. What happens is I've put a tryphan blue. In this case, I am not shown it, but now what I do is wherever the area of zonular dialysis is there, I put a cohesive viscoelastic so that the tryphan blue doesn't go behind. And see, this is what happened. This was the most recent case I've done. I put a tryphan blue. I was waiting for a tricot injection, and it has trickled back, and I could not see anything when the retro illumination is not there. So it's a very important step to not let your tryphan blue go behind. Your visualization aids in your surgery. A clear phaco incision of 2.8 was done. You could see that the zonular dialysis is almost around 5 clock hours. So I've started the CCC in the opposite direction. Using forceps gives a more stable approach. Some people also use hooks during the extension of the rhexis so that it stabilizes the bag more. This was a traumatic young patient, so it was fairly stable. A gentrohydral procedure was done. You don't let the whole wave come to the opposite side or pop it out. Just enough to release the corticocapsular adhesions. Since this was a large 4 to 5 clock hours zonular dialysis, so after this, just small bolus of injection. I've decided to fix the bag first with 4 capsular hooks. And then I've decided to rotate it because it has distributed the forces well. The anterior zonules were pretty fine. Going ahead with the phaco surgery, lower parameters, a direct chop technique. Important is to lift it slightly in the capsular plane or the iris plane and remove the pieces because it will prevent the bag stress. You lift it with your second instrument and get it in the central safe zone and emulsify it. If you can see in the quadrant, you may see some fluttering of the PC, and you have to be very careful about it. Otherwise, the whole bag may just come out. Replenish with OVDs so that the PC is pushed back. Even with lower, now this is the last piece. I just thought I was relaxed and done, and just see what happens now. Okay, the PC just caught. I'll just slow it in show motion again. Use timely reflux and left it back. Take your time, put your cohesive viscoelastics. There's no PC rent, it just had caught and I have left it at time. The cortical cleanup was done. So in this case, I preferred to put a CTR after doing this because the bag was fairly stabilized. I preferred to do it with the injector because you can place the eyelets opposite side just by going from the same wound. Otherwise, you need to put it through another side port. See, it will come in the opposite and it will stabilize the bag now. Next is a 3-piece IOL was inserted. The trailing haptic is important in these cases where there is a lot of zonal stress to not dial it, but you can just place it. I use a bimanual technique where I just depress the optic and just place it under the margin instead of dialing and rotating it because that will cause more of disruption of the zonules. Removing the capsule. The bag looks very stabilized. I didn't want to put a CTS segment because it was a young patient, traumatic, and I felt the lens was pretty stable. So I did not want to do it too much of intervention. And that's it. That was the end of the case. Yeah, that's it.
very comprehensively explained, Ronak. It was really good. All the points were very well covered, and I think all the points were, each of them was very important. So we'll move on to our next speaker. Dr. Aarti Agarwal is going to be speaking on my first phakic lens.
Hello everyone, a very good morning, and thank you Dr. Zain for inviting me and letting me share this first experience for my phakic IOL. So this is back in 2016 when I started my practice. Just 2 months into my clinical private practice, I come across with this patient. Young female, 24-year-old, quite motivated because she was wanting to go further for further studies abroad. So she came to me for a refractive opinion. Refractive error very high, as you can see, -9 with -2.5 cylinder in the right eye, with Pachy of just 438, with good anterior chamber depth, likewise in the left eye. So straightforward thing, that refractive error is high, pachymetry is low, good internal anterior chamber depth. So when we are talking about planning a phakic IOL, one thing is we are checking the internal anterior chamber depth, that is from the endothelium to the anterior lens capsule. And then, so it was a straightforward case. I went ahead discussing her options for phakic IOL. Back then in 2016, we did not have RIL. We just had the options of ICL, Ipcl, and biotech Acryl. Due to the cost constraint, she opted for Ipcl, and that was something which I was quite apprehensive, because back in my fellowship days, I had only done ICL. So for me, it was a challenge to do an Ipcl. So this is just an illustration, because back then in 2016, we didn't know that mask has to be used even outside the operation theater. Like any of us, the first case, we are going to do over-counseling. So I counseled the patient about all the risk factors, everything which was involved, what I expected out of her, what she needs to expect out of the lens. And then she decided to move ahead. So this is my normal protocol, which I'll be discussing very quickly, how I proceed with the phakic IOL in my center. So I have made this chart, which helps me not forget even one single point when it is, because it's an extensive workup which you need to do. Going stepwise, first important thing for any surgery is to rule out, any extraocular defects, especially in high myopes. There are possibilities of phorias and tropias. So this is something which we need to see. Very, very, very important in any refractive surgery is to do your own refraction. This is one thing which will really take your refractive practice a notch higher. Do your undilated as well as your cycloplegic refraction only by yourself, and do not trust any optometrist. A good slit lamp examination to rule out if there's any cataract, that is one of the very important thing to document. Of course, along with cornea, how clear it is, and the other anterior chamber and other details of the eye. Very, very, very important in refractive as well, especially when we are dealing with phakic IOLs and high refractive error, is checking a detailed retina examination. If you're not very comfortable yourself, go ahead, referring the patient to a retina surgeon, which I usually do in my clinical practice. If the refractive error is more than -8, before going ahead with any kind of refractive procedure, I take a retina opinion on paper. So then comes the evaluation of the lens. So optical biometer is one thing which we need to do for white to white, of course, for the anterior chamber depth to reconfirm, and also for the keratometry and the axial length. Because these patients later on, when they come for cataract, it becomes easier for us to manage and calculate the IOL. So here, although I had a pentacam, I still did Cirrus, because Cirrus, I like to do as many as investigations for my white to white calculation, so that my IOL, my phakic lens power and the sizing is, doesn't go haywire. The most important step is to do your white to white calculation by using a digital caliper, because of course your optical biometers and your topographies will give you a white to white, but it's always a good habit to do your digital white to white calculation, and then match it with your other parameters. For me, I always do my calculations myself. I although give it to the company person also, but I make sure that I'm doing my calculation myself, because especially when we are doing digital caliper calculation, we are not taking only one reading, and we are taking multiple readings. So what I do is I feed each and every reading and see how my sizing is going up or down. If suppose it's your first case or you are not very confident, go ahead giving the parameters to the company person, and they are fairly doing a very good job, because till now I have not had any discrepancy. For this case, it was a fairly simple, very straightforward case. I went with sizing 12. Coming to pre-operative, most important, like Dr. Zain said, that marking in sitting position is very important, even if you're not doing a toric phakic IOL, because when you're doing a phakic IOL, your calculation depends upon your incision. So irrespective of whether it's spherical or a toric, marking is very important in sitting position. I'm more comfortable using a mercury marker, so that's how I do it in my practice. One can also do a slit line marking. So coming to the loading of the lens, so first thing is, whenever we are doing a phakic IOL, we are loading the lens first, rather than we are operating on the patient first. Why so? Of course, in IPCL, we have a backup lens, but it's always a good habit, because it's a premium surgery, young patients. You don't want to make an incision and then load and see that you have a disturbed lens architecture. So always a good habit that you load the lens and then you start with the procedure. Loading of an IPCL is fairly simple. It's just like any plate haptic PCIOL. Very important thing is, don't completely fill the cartridge with Visco. Partly with Visco and partly with saline, because if the cartridge is filled with excess amount of Visco, it can lead to flip. Step 2, what I do, this is my personal customization, because I had 2 flips of IPCL, so that's when I decided, because there are so many holes, there are identification hole, aqua port, and then you sometimes have air bubbles, or sometimes you have Visco bubbles. So when the lens is unfolding in the eye, it becomes really difficult to identify where your leading hole is. So what I do is, just using a little marker on the right upper side, I just do a tiny marking, so that when my lens is unfolding in the eye, my concentration is only on that ink mark and not to see which hole I need to follow. Step 3, just like any PCIOL, like I said, plate haptic, you go ahead loading the lens. It's the most simplest way of, the most simplest phakic IOL to load is IPCL. Coming to the surgery, of course, doing painting, cleaning, draping, explaining the patient, putting good anesthesia drops. Important for this is, we need to take 2 side ports 180 degree apart, because this is very convenient for maneuvering. Main port, we've discussed in details how to do it. Coming to the surgery, be very generous in using viscoelastic, because we don't want to touch the anterior lens capsule. So like you see now, and phakic IOL is not done wound assisted. You have to go inside the wound. For IPCL, you can make 2.8. For ICL, you need 3.2 incision. So now you can see, if as my lens is unfolding, my concentration is only on that mark. So this makes your surgery very easy, and especially when you're a beginner, this is a very good thing to inculcate in your practice. Just one tip here I'll give you all is that when your lens is unfolding, so when you are halfway through the lens is out in the anterior chamber depth, just take a second or two, see how the lens is. If in case it's flipping, you can still at that time also reflip it. Then go 25% and then the last 25%. So if you go in stepwise manner, you will never land up in any problem. For a phakic lens, we all know
Dr.
that...
Aarti, we are running a bit short.
Yeah, I'm just in my last slide. Tucking is very simple. I'm not talking detail about it. So thank you. So this is actual patient back in 2016. She was very happy, and the journey of phakic lens does not conclude at just completing the surgery. It actually begins from there, where you have to actually check the patient post-op, vaulting, and IOP. Thank you. Thank you so much, Dr. Zain.
A very good talk, Dr. Aarti. I really like the fact how you showed yourself doing all the steps. I think that was key. Our last talk for the session is Dr. Neeraj Israni, who's going to be speaking on my first secondary IOL.
Thank you, Dr. Zain. So my talk for the day is my planning your first secondary IOL. So in my case, the first secondary IOL that I planned was the iris claw. So most of my talk is on the iris claw. Now, complications are one thing that are imperative. It is something. It is said that if you don't have complications, you're either not operating enough or somebody else is operating for you. So I believe that it is a phase of your life, and it is a phase of every surgeon's life, and you have to just be with it. Now, what are the indications for a secondary IOL? So, when we see management of aphakia, it can be during a primary surgery or it can be during a secondary surgery. So, just noted down certain points like crystalline lens subluxation, IOL dislocation, capsular loss during cataract surgery, or any complicated phaco for senile cataract can be some of the causes for a secondary IOL. So what are the surgical options that are actually available for correcting aphakia? So I believe that transscleral sutured PC IOL is probably the best because it is the closest to the nodal point. However, we all know that it has a very steep learning curve, and you have to actually practice a lot of cases, only then you become an expert. Angle supported ACIOL is something we've all done during our residency days, and we've all started with those kind of ACIOLs. Then came the iris fixated or the iris claws, which have been there since quite some time. So if you see, the first ever iris fixated lens was the Binkhorst and the Wurst iris clip. And this is actually a picture from 1980 from the Indian Journal of Ophthalmology. And if you see the enclavation at one of these points, so if you see the enclavation over here, I'm sorry, it's not. If you see the enclavation, it's slightly superior temporal, and it's not temporal. That was probably because in the initial days it was easier because the side ports were made on a different axis. And the artisan aphakic IOL, which is not very freely available in India, that was again one of the FDA approved ones in 1995, I believe. Now, like I told you, my talk, because this was my first secondary IOL, so we know that the iris claw can be clipped anteriorly or posteriorly, and the anterior reasons are different, and it's mostly for correction of myopia, and posteriorly the iris claw is put mostly for aphakia. So this is one of the patients that I had seen, not operated by me, but as long as the iris claw is placed and inclubated, it is very close to your endothelium, so the chances of a decompensation are very high. And this is another patient where post-trauma of the anterior placed iris claw, there was a trauma and it actually got de-enclubated and started causing a little bit of decompensation. Whereas in case of a retropupillary iris claw lens, as you can see, the results are much more better. Now, what is the usual situation that we need this? So obviously presence of aphakia, that's the first thing. If there is a vitreous prolapsing, if there is a lack of capsular support. And so it's said that for iris claw, you need two things. One is iris and the other is iris claw. So it's very important that you should also have the iris. Just want to say that when you perform a vitrectomy, there are certain things that you should keep in mind. Your vitrectomy probe should be placing upwards, and it should be slightly more posterior as compared to the anterior plane, so that it actually sucks all the vitreous. And make sure that you don't sweep the iris, because like I said, iris is very important in this case. So the first thing that is there is to free the anterior chamber with the vitreous that I've already explained, and you have to make sure that the vitreous is cleaned completely. So the second is basically to assess the iris. So if you see the pupillary zone, that is the area where there is constrictor pupillae. So that is the area where you're not supposed to enclavate. And the mid-periphery of the session, mid-periphery is the area where you actually enclavate it. So I'm just going to quickly show a video over here because we are short of time. So this was a case of a subluxated lens. And if you see over here, we planned a SICS for this patient. And what we saw that because it was a subluxated lens, we could actually not salvage the lens. And during the explantation of the lens, there was also a lack of iris. But I still went ahead and I performed, I took the iris claw and I had a good support because my side ports were temporally at 0 and 180. That's very important in iris claw, that your side ports are not aligned at 11 and 2 and they're actually temporal, so that you can actually enclavate the iris claw really well. So I'll just forward to the, so we had the vitrectomy done, and as you can see, that's my iris claw. Now it's very important that when you take the iris claw, you actually tent the iris claw in this position and then enclavate it. So that actually gives you a good, and you hold the optic in the center. So I'll go to the next video because we are short of time. Can we conclude? Okay, so I think we have shorter time. Yeah, so these are few of the lenses that are available in the market. And yeah, these are few of the IOL holding forceps. I use the Leberman forceps from Appasamy, the T forceps. So lastly, just my last slide, I'll just take a minute. So it is important to learn from our complications, and complications are a part of a surgeon. So, you know, iris claw is one of my first secondary IOLs. And yeah, that's my talk. Thank you.